All right. Well, good afternoon. I think we'll go ahead and get started and anticipate that folks will be joining. As I can tell, they're adding to the participants list. I'm Kristen Faseri. I am a partner at Accenture. I lead our North America healthcare practice, and I'm also privileged to be a board member for EHI, and also I'm very privileged to be facilitating this panel with a really esteemed group on a really important topic. So the way we're going to use, we have about 55 minutes today. We're going to introduce our panelists and let them have a moment to outline a little bit about what they are doing in their respective organizations around health equity. And then we'll dive into some questions. If there's an opportunity for some Q&A, I certainly will allow that, although I may need some. I'm not as an expert on Zoom, so I may need some help from my team here. But if it's okay, I think we'll dive into this really important topic. Today's panel is really about the role of driving health equity through diversity in leadership. And all of us are leaders in our respective organizations in healthcare. And certainly the panelists you're going to hear from are. I think about some of the conversations I'm having with clients, including one just yesterday. It was with the chief strategy officer of a major Blues. And he was talking about how they have just launched their diversity and health equity part of their organization and hired a new leader. And he said it's really a big change for their organization and a real opportunity for them to get closer to their community and create leadership and visible leadership in the community that they serve. I'm just going to ask, if you're not speaking, if you would mute, please. That would be really great. And if somebody could help me, that would be wonderful. All right. So let's dive in, and we're going to talk about this topic with, as I said, three esteemed panelists. And I'm going to start with I'm going to give a quick introduction and then allow them to talk a little bit about what's happening in their respective organizations or in their respective research. I'm going to start with Dr. Jorge Rodriguez, who joins us from Brigham and Williams in Boston. And Dr. Rodriguez is a technology equity researcher and hospitalist in the Division of General Internal Medicine and Primary Care at Brigham and Williams, or Women's, I'm sorry. And he completed his internal medicine training at Mass General, and he's also completed a clinical informatics fellowship at Beth Israel, also in Boston. And so he's currently focused on bridging disparities in patient-facing health technology, including the patient portal, mobile apps, and telehealth that this wonderful health system that he's a part of utilizes. So Jorge, I'm going to ask you to just kind of kick us off and talk a little bit about the impact you're seeing around diverse leadership and the use of digital tools to meet the population.
And Roy, you do Roy in the end. Oh, and you have that.
Sounds good. Thank you so much. I'm really excited to join the panel.
You can hear.
I think we're getting some feedback there. As you said, my work focuses on addressing digital disparities and digital inclusion more broadly. And as I've continued to do work in this space, I've started to realize that having diverse leadership is such an important foundation for digital health equity more broadly. And so over the next few minutes that I have here, I'll share a few reflections. When we look at the current state of digital health environment, we find that we've really created applications and platforms that have not been tailored to the populations that could benefit from them the most. For example, if the audience would follow me for a second here, I'd like them to imagine their favorite app, that app on your phone or on your computer that you use all the time, and keep that in mind as I'm kind of going through the next part here. Then I'd like to tell you about one of my favorite studies. This was a study done by Dr. Umali Sarkar over at University of California in San Francisco. And in this study, they worked with patients in unserved communities at a safety net clinic and helped them assess different health apps. So what they did was they took health apps off the App Store, and they asked patients to perform data entry tasks and data retrieval tasks, which are sort of common tasks that we do when we interact with an app. after kind of going through all that, the patients were only able to complete about half the tasks. Now, if you think back to that app, your favorite app that you were using, and you think, if I were only able to complete about half the tasks I do, if you're only able to post to Twitter, but not actually read the post, it wouldn't be a very useful app. And so similarly, we performed a study where we looked at how many diabetes apps were available in Spanish, for example. And our thought was that because diabetes impacts Spanish-speaking patients disproportionately, these apps would certainly be available in Spanish. Yet when we looked at 92 apps, only 22 of them were actually available in Spanish. To give you a couple more examples, just to drive the point home around digital disparities, we can look at the development of artificial intelligence and the lack of data from diverse communities and how that's impacted their development. There's a classic example of dermatology tools that performed worse on darker skin and better on lighter skin because a lot of the training data they used lighter skin photographs. There's even data showing that pulse oximeters, the tools that we use to measure blood oxygen level and really treat our patients, perform worse on darker skin individuals as compared to lighter skin individuals. And this has been the state of digital health. Now, leaders can play a role in addressing these challenges, but there too, we run into challenges of diversity amongst the leadership of digital health companies. There was a recent survey done by a company called Rock Health, where they wanted to look at the diversity of leadership at digital health startups. And they found that Black and Hispanic or Latinx leaders were underrepresented, making up only 8 or 6% of the leadership at these companies. So if you think back at that discrepancy, imagine what some of these apps or these platforms might have looked like had there been diverse perspectives and stakeholders at the table. Perhaps some of these leaders would have reflected on the impact of these tools on diverse communities and taken a step to highlight and say, hey, should we develop these in multiple languages? Should we make it a bit easier to use? Is our training set diverse enough? But those conversations were not had when these tools were developed. When we look at healthcare organizations, we've seen similar patterns play out, especially as it relates to the rise of telehealth during the pandemic. For example, we know that amongst marginalized communities, they had less access to video visits. And some of the work from our organization, we found that Black, Hispanic, or Latinx patients, non-English speaking patients use video visits less, relying more on in-person and telephone visits. And it sort of demonstrates how technology can actually worsen disparities rather than improve them. And now, again, this was driven by multiple factors. There's all sorts of stuff that goes into sort of the gaps in telehealth access. But I think it really reflected some of the leadership choices that were made even before the pandemic. We knew, for example, that patients from marginalized communities were less likely to use patient portals before the pandemic, but leadership priorities were not aligned with addressing those needs at the time. And then we just saw that sort of the impact of that once we were really pressed to use these tools. So we're in a place right now where digital tools can really play and will continue to play a larger role in the way we deliver care. So it's essential that we take the opportunity to reflect on who's leading these efforts in order to create these culturally and linguistically tailored tools for our patients. And that, as I said, that really starts from the top. And we can think of all the innovative things that we can do with these digital tools, but it requires leadership not only at digital health companies, but health organizations who reflects and understand some of the communities that could benefit from them the most. So where we go from here, I don't want to leave everyone with a very like, oh no, what have we done? So I want to leave with some action items here. I think that, on the one hand, I think health organizations can commit to fostering workforce diversity programs, especially in digital health and technology, to really develop that leadership pool. And I'm sure my co-panelists will get into all of this. Similarly, supporting and actively recruiting leaders from diverse communities. And this includes investing directly into the communities. I'll take a moment here to kind of share a personal reflection from my own journey. When I was in junior high school, I went to junior high school in a public school in New York City. I was part of a program that helped foster all sorts of leadership skills and educational skills for underserved communities. And it really changed the path of my career. I can literally remember when I was with my mom on the M train, for those from New York on the M train, going across the Williamsburg Bridge and making this decision whether I should go apply for this program or not, because we were running late, as we always did. We were running late, and that one moment really defined where my career path went, and that was a result of investments of organizations in the communities that they served. So I think there's opportunities there. The other component of this is tracking equity metrics of these digital alternatives, including at leadership positions. Who's at the table, who's not, how does that reflect the communities that we're serving and the care that we're delivering? I'll share another personal example. I'm full of personal examples today. This one is an interesting combination of my research and some leadership positions that I've held. A few years ago, we performed a study where we looked at the websites of federally qualified health centers and whether they were available in different languages. After doing this study, we found that only about a third of them were actually available in other languages, despite the fact that a large amount of limited English proficient patients get care at federally qualified health centers. Then a few years after that, I held a leadership position in one of these very community hospitals, and this conversation came up. I couldn't believe it. I was like, oh my gosh, this is research being applied. And so we were in this boardroom making a decision of how do we remake our website? Should we have it available in different languages? And at that moment, because our leadership team was quite diverse, we included multiple Spanish speakers. We knew the community we were serving was primarily Spanish speakers. The decision was easy. It was just like, should we do it? Yes. Okay, let's move on. And it helped us, really make a decision where technology didn't worsen disparities, but perhaps help them in some way. I'll add a few more action items here. I think there's also great work to partner with academic or community organizations and industry to really kind of foster leaders in the development of these tools. There's great work being done. Again, I always give a shout out to UCSF. UCSF has a group called the Solve Health Tech, where they're actually working with digital health companies to focus on Medicaid and vulnerable populations. So really taking a leadership role in the way they're driving care towards underserved patients. The other thing I'll note is that healthcare organizations really have a good amount of buying power, right? When they're going and they're saying, I'm going to purchase X telehealth platform, they can really take a step back and go to the vendor and say, okay, I'm the leader of this healthcare organization. What have you done to develop your tool in a way that engages marginalized populations? Were these populations involved in the design process? And then they can use those answers to say like, you didn't develop any of that? Well, maybe I'll take my business elsewhere. And those are ways where we could really make decisions that have more broad impact in the way care is delivered. The other 2 points I'll leave you with are, one, I think understanding that a lot of the disparities and inequities that we're seeing are driven by structural barriers. And so in order to change all of it to some extent, you need these diverse leaders to actually change these structures so that we can move closer to health equity. And then finally, as I reflect on sort of all of this that I've just said, I'm reminded of a piece by Dr. Thomas Lee in which he reflects on the role of leaders in driving healthcare organization. And he highlights a quote that always sticks with me from Ralph Waldo Emerson that says that organizations are the lengthened shadow of their leaders. And so I'd say that having diverse leaders, we can not only ensure that the organization represents their leaders, but actually represents and are lengthened shadows of the communities they serve. So with that, I'd like to thank you so much and looking forward to the conversation.
Thank you, Jorge. That was great. I especially love your story of the M train. And I just heard a speaker talk about defining moments. And that was a defining moment for you. And I think as leaders, we have a responsibility to create defining moments for others. And so fabulous story. My next panelist is Dr. Ian Tong. Dr. Tong is the Chief Medical Officer for Doctors on Demand. And he has spent his entire career working hard to improve access to high quality care. And prior to joining Doctor on Demand, he had multiple medical leadership roles, including at Stanford as in the internal medicine chief residency program. And he was the founder and medical director of the Health Resource Initiative for Veterans Everywhere, called Thrive. He completed his undergraduate degree at the University of California at Berkeley and a medical degree from UChicago, and completed his residency at Stanford. And he is board certified in internal medicine. So Ian, would you discuss the impact of the barriers of structural racism and your thoughts on what's keeping Blacks, Latin Americans, and Native Americans and women physicians from leadership opportunities, as well as any other topics you want to make sure you include in your introduction?
Yeah, excuse me. Yeah, thanks, Kristen, for that. And yeah, it's great to be here with Jorge and Elena, and we haven't all met before, and so just getting to talk about these type of topics with you all is it's a privilege, and I think it's going to make a difference too for people to see us and hear us. and help them understand, why we are in the position that we are in. And so maybe just to say a couple things. So I'm an internist. I've spent, a lot of my career thinking about how to improve access to high quality care. Early on, that was for homeless veterans. I was given a job at the VA Palo Alto healthcare system, doing outreach, and actually had a mobile clinic. And I was able to write for a grant early on in my career that actually included outreach to rural veterans. And so it was when we were thinking about rural veterans is how I got introduced to virtual care, what was called telemedicine then. And and I was really amazed at that time. This is 2007. This is before your smartphone had a camera on it, actually. So I was trying to take a laptop and using the camera that was on those laptops and a wireless card that we would slide in to the side of the computer, and then you'd kind of flip up the antenna and try to get a wireless connection. So essentially turning your laptop into a smartphone, if you will, was how we were doing this in sort of the 1.0 version of it. We've come a long way since then. And so the work that I'm now doing in our newly branded company, because we merged over this year, is Included Health. And what we have done is we've taken we really think we've created a really unique healthcare company that's taking healthcare delivery as a functional, a core component of what we do. And then we're layering in and around that navigation and advocacy for our patient populations. And so the idea here is that that you want to have as low a friction point or as many points of entry for a patient that are the correct point of entry, or no wrong door would be another easier way to probably say that they really have no wrong door, that you're improving access for all individuals. And all of that is through a mission to improve the standard of care for everyone. And that's the mission and goal of the company. And so the question today we're talking about is really so how do we do that? Through diverse leadership. Just one historical point that I think maybe everyone here probably has heard before, but maybe not everyone that's in the audience, which is that there was a report that, there used to be a lot more medical schools and education pathways for people of color in this country. But and there were actually a lot more medical schools for white Americans as well. But in the Flexner report in the early 1900s, I think it came out around 1910 or 1913 or something like that. This Flexner report really went through and evaluated the rigor of and specifically the scientific rigor and scientific approach that all those different schools were taking. And unfortunately, in their judgment, they really disproportionately removed the pipeline or the medical schools that were actually enrolling and giving opportunities to people of color. And so what we saw was a really huge impact of the pipeline there. And so if we're talking about leadership, I feel like we have to start kind of well, where do those leaders come from? And so really it starts early in our education, where we have to provide equitable opportunities for people to get access to that, to the skills and expertise and experience that they can then pass on to the next generation. So I'm a pretty firm believer that as an educator that, and I know Jorge and Elena probably feel the same, right? We probably all do some portion of our work as leaders, clinicians, but also as educators and also policy, professionals and so on. I mean, there's a lot of work to do to push this forward, to make this happen. But that background is an important thing to understand, because if I think about my grandfather, who actually was a doctor, I'll tell you, this is my personal story, right? My grandfather was a doctor. My grandmother was a nurse in the Bay Area in Oakland. At that time, about 3% of the doctors in the country were Black. So here I am in 2021. And we can say a lot of work has been done, but only about 4 to 5% of the doctors in the country are Black. So I think we have some very hard evidence that says that we've left a major part of the toolkit out here, which is really emphasizing education and opportunity for individuals from these communities to pursue that. Once you've done that part, you can then see how you begin to find opportunities for individuals to lead. And I would say, almost in my experience, when I was at University of Chicago or Stanford, there were some opportunities to potentially be a chief resident, for instance. This was in my bio, but it was not a given that role was going to happen. In fact, it was not a given that I was even going to get an interview where I trained for residency. And I'll just give you one more personal story there. that I became aware of as a chief resident, which was that where I did my residency at Stanford, it was much harder to get an interview, actually, and to get invited to an interview if you came from a historically Black college or university. And so, and that was just because of one administrator in the office who did one level of screening of applications, and that person didn't have, it wasn't a, this is a very well-meaning person, but someone who literally just had unconscious bias. And maybe some of it was even more conscious bias about equating diversity with a compromise in quality somehow. And so this is wrong. This is wrong. This is incorrect thinking. And so we really have to look at our institutions and the individuals that may be in a gateway position, and we have to really examine ourselves. And I think, to Jorge's point, research that's done on that, I think would similar to the research that has been done on looking at interview processes, for resumes that are de-identified in every way other than, I'll use one example of de-identified in every way other than someone's scholarships, maybe. And so someone who has gotten need-based scholarships, for instance, is less likely to get an interview in the application process than maybe somebody who received a country club scholarship or something like that, right? Just even that nuanced, very subtle signaling to individuals that review prescriptions really provides a huge gateway function. So anyway, so fast forward to where we are, I think now is, and just making maybe the other big point about leadership is at our board level. And so I'm sitting in corporate America now. So at the board level, there's very little diversity within the boards. And I think Jorge was really speaking about this. What would happen if you had at the birth of the AI and machine learning tool that Amazon put forth out a couple of years ago, right? That they were promoting and saying, well, we can recognize faces, and we use this facial recognition software to really help do all sorts of things, including identify criminals. There's a nice movie that's made about that called Coded Bias that I would definitely encourage everyone to take a look at. We can see how having the right board member in that room, or the right leaders in that room, or the right developers early enough in that project, or just even getting a consultant who has some experience in this area to really help these companies avoid these pitfalls, I think would be extremely important, just for the quality of their end product, but also creating, again, that leadership pipeline that's so important in terms of for their organizations going forward. So at the board level, the C-suite level, director levels, and VP levels, we need to really make a concerted effort to do that. So the last thing I'll say about that I think puts us on that path is we have a great deal of unconscious bias. So even if you have a program that says we can get people in the pipeline, and even if you have people that can get on the board and the VP level, you still have so many people across your entire organization that still can provide, that might sit in a position where they're in the gateway function of preventing someone from moving up, being promoted, and so on. And these again can be very well-meaning people. Certainly some of them can have racist views, but they really need to have a much more anti-racist agenda, I would say. And that comes from acknowledging that they may have implicit bias or unconscious bias that affects their decision-making, and it might affect how they assess someone's readiness or appropriateness for a certain position or someone's performance. And so, I think we're going to go a long way, I think, to educate ourselves around implicit bias and unconscious bias, acknowledging it, and providing people with the tools to educate themselves and recognize that this is in play, and when it is in play, and then give them a few things that they can do to really help, prevent the knee-jerk reflex, or being guided more by their bias than actual performance or facts. So maybe I'll pause there. Yeah, I'm looking forward to getting into the conversation. I think there's a lot of examples for some of the different things that I've highlighted here, but just to remind everyone, I think the pipeline is super important. And then I think being very deliberate in our leadership choices and opportunities there, and making sure that you don't just have one person that's just, that kind of checks that one box, but anytime you're going to do that at your board or C-suite, if you can find two people, to really provide representation, having two women, sort of like, for instance, not just one woman on your board, but two women on your board, and so on. These are things that I think we should really not just check the box, but we really need to push ourselves to go beyond that if we want to see the more rapid change that we need in this country.
That's great, Ian. Thank you for that. First, I love the story of your grandparents or your parents. I think you said your parents. What a inspiration to be multi-generational. And I think you shared some really sobering statistics, triggered a lot of questions in the chat, which I'm going to ask. We're going to come back to because I want to have Elena introduce herself. But there are some great questions about pipeline and opportunity, some advice we would provide or this panel would provide to aspiring clinicians. But let me, if you will, let me go to Elena, and then we'll open up the floor, and I'll get back to these questions because they're really great ones. So our next and final panelist is Dr. Elena Rios. Dr. Rios serves as the president and CEO of the National Hispanic Medical Association, which represents 50,000 Hispanic physicians across the United States. And the organization's mission is to improve the health of the Hispanic population. And she also serves as the president of the National Hispanic Health Foundation, which directs educational and research activities aligned to that mission. She's on multiple boards and committees focusing on health equity, and serves as a health advisor to many others. And she's a frequent lecturer and also has several published articles and leadership awards to her name. So Elena, I'm going to hand it to you to just discuss, as you introduce more about yourself and your background and your passions, opportunities for leadership development that you see for physicians. And actually, I think we'll get to some of these questions, or at least kick it off, especially medical students and residents who are engaging in the profession at the beginning of their career.
Thank you. Yeah, no, great to be here, and thanks for the panelists on all the work that you do and your insights. I won't dwell on so much that you've already talked about in terms of, I guess the importance of tech and changing technology with leadership. I think the issue here is really about the pipeline. I think that's what I was asked to focus on. So with the National Hispanic Medical Association, let me just say I'm from California, from the Los Angeles area, and went to Stanford undergrad in the 70s. Yeah, Stanford, and went to UCLA for public health school, and then went to medical school. And I think through those years, and I also went internal medicine, and then I did a fellowship on health research that was really about policy, and it's the NIH NRSA fellowship, and that was done at UCLA too with the general internal medicine faculty there. I think the importance from my story is that I got to meet a lot of activist type students, Black, Brown, Native American, Asian, in the 70s, very interested in understanding and being proud of where they came from, and also understanding, I think we all got the mandate, we all got the memo that we were privileged to be at Stanford University, and that we should become heroes, leaders, if you want to call them leaders, heroes for our community, and whatever that meant. And I was pre-med from day one. I had already worked in a hospital, and my mother was studying to be a nurse, and a community hospital. And I think what was important to me was understanding what that meant, what was community, and what was our responsibility as privileged students. So I think looking at a pipeline effort, students have to realize that it's more than just them. And they have to be empowered to know that they are going to get something very, education you can't be taken away from you, right? And that students in our communities need to understand that if they get to college and they want to become a doctor or a nurse or a dentist, that they have to work hard for it. But there are many rewards at the end, and we call that delayed gratification. I think that's an important message. But the other important message is you can't do it alone. And I think we learned way back then that our family were our other colleagues, our students, our faculty, our the people who helped us, tutors. And as a Latina at Stanford in the 70s, I made a lot of friends who became lifelong friends. One asked me to come and work at the White House in 1993. Another one is now the HHS Secretary of the Department of Health and Human Services. Other friends of mine became heads of their own organizations who were at Stanford at the same time. And so anyway, this national network has followed me. And I think if people need to understand that as minority students, even though you feel isolated, there's not that many of us. And as you go up the ladder, whether you go from college to let's say medical school to residency or whatever health profession you go into, the further you go, the more isolated you are. So thus the real opportunity is to develop mentoring and to develop networks. And that's why we started the National Hispanic Medical Association. There's been student clubs and student groups. And when I was at UCLA in medical school, we started our own California Chicano Latino Medical Student Association and got the 9 schools together. And we had little speakers bureaus to go talk to we paid undergrads to have medical students talk to them at their clubs. And we connected to Texas. And anyway, we ended up starting the seed for a national group that's now called Latino Medical Student Association. And the National Hispanic Medical Association started because we knew that we were the first critical mass of Hispanic doctors in this country. And at the White House, working on health reform, we realized we couldn't find Hispanics to be part of the meetings with the Healthcare Reform Task Force. So I was asked to find Hispanics in different health professions, nurses, social workers, hospital executives. And so to have a network is very important that can support each other. And then after that, I'll just say that the importance of leadership. We have used leadership as a qualification for our programs. So for scholarships, we decided to have a scholarship program to give back to medical students, dental, nursing, public health, pharmacy, and even PAs. And we require documented leadership. Now, why? Because we want to find students that are like us, that are interested in doing more than the 9-to-5 job and having motivation to changing their communities, improving their communities. We started medical student mentorships. We started residency program, leadership programs. Not so much leadership in terms of get to the top levels, but just be a leader within your own world and decide if you're going to go into academics, what's the leadership pathway? If you're going to go into private practice, what's the leadership pathway? And in understanding that you have to have support, funding, direction, mentors, all those kinds of things to build your pathway forward. And we now have, and we have had it for quite a while, we have an NHMA Leadership Fellowship for doctors who are at the minimum mid-career. And we say that's 5 years after training, because that's when you really understand your own, what you like or don't like about your job, your setting. Do you want to work in a hospital? Do you want to work in a nursing home? Do you want to work in private practice? Do you want to be an owner and control your decision, business decisions? Are you going to be faculty and help with research or develop, be a role model in the faculty world? So I'll just end with our leadership fellowship, because that's been our flagship program, and just about all of our board members are from that program. And we were able to develop a national advisory committee of not only doctors, but others who are change agents within healthcare in different types of healthcare organizations. And we've had speakers dealing with the importance of leadership styles and leadership skill building, like negotiations, like stakeholder mapping, where you get to understand if you were a leader of let's say a hospital, or you're a leader of a public health department, who do you have to work with, and how do you convince them that to argue for something that you think is right or needed. And besides leadership skills, you have to have an understanding of what is health disparities and how can we get to health equity, and listen to both sides of the issues. So in Washington speak, we talk about the people on the right and people on the left. one way to listen to them is to hear from think tanks. Think tanks in Washington, D.C. are some are conservative and some are progressive. And we bring those types of those types of people. We also talk about the media and how you work with media. How do you develop your own op-ed? How do you develop your voice? So these are the types of people that we have. It's not just a medical focused, it's about health disparities and how do you change the agenda wherever you are as a leader. And we hope that most of these physicians in our leadership fellowship would get more engaged in the public health arena or technology arena, where you can have a broader impact than just in a small clinic or a small office. It's more regional or local. Anyway, I think, the only other lesson I think that we've learned with our organization, it's about 25 years old now, is how important it is that leaders have other networks and that we share and learn from each other on what works or what doesn't work to actually make change and to be a catalyst. And to get onto boards, I think that is our next focus area. I've been on advisory committees, one corporate board. I think it's important to get into the corporate sector in terms of being able to add diversity to the voice of the voices of change within the corporate sector, wherever you're at. I was on an insurance company board, and it was local. But I think it's also important to understand, to get out of healthcare and to get into the business sector, because more people need to understand what health equity is all about. I mean, just the importance of what we went through with COVID-19. I think more on the private sector are going to want to know how to get their employees to be healthy. And also, we now know how many essential workers in this country are minority, and there needs to be more voices from our diverse healthcare experts to be on the corporate boards that inevitably are going to have more diversity within their employees as we move forward. And, so I'll just stop there, but there's a lot to talk about.
Elena, that was great. And I love the points about networking and the importance of actually building networks upon networks. And I recently participated in a panel around board membership, because California's got some legislation tied to increasing diversity, and the importance of when somebody in your network or a friend of your network calls, answer the phone, pay it forward. And I think that's kind of what you're saying as well, as you're building this really activated network. There's a lot of questions in the chat about pipeline, and I think it's really relevant about, we're all very focused on talent and building a pipeline of talent, diverse talent that can be really a champion for what we're talking about. I think back, Jorge, to what you said about your pipeline out for yourself almost began when you were a young student. I guess for each of you, maybe comment, what do you think some of the things that the leaders on this call can be doing or should be thinking about to build a pipeline in either tech or in the medical field to really drive towards this aspiration we all have to create more equity in healthcare? And Jorge, I'll start with you if that's okay.
Sure. Yeah, I think it's a super important point. I'd say that investing in the communities that where they are and that they serve, I think is like the big thing I'll take away. Like, not only did I benefit from that program, but my wife, who I met in that program, also benefit from that program. And so I benefited in multiple ways, because I had education and career and leadership experience. And also I met my wife in that program. And so I think it's important, I'd say, to invest in the communities that they serve and that they're working with, to sort of like ensure that you're creating this pipeline really early on. We were young. We were like, I think I was 11 or something. And so we were pretty young. So that's what I would say in terms of like building up that pipeline from the get-go.
I would just add in, I mean, that's, by the way, I love that, Jorge. I'm learning
I
a lot.
love that story. I don't know if anybody ever met their spouse through some of these leadership training programs, but that's great.
Well, I mean, we're laughing about it, but I actually think it's a very real thing, and I feel like Elena said it as well. Like it's, how to say this? You have so few people across the entire pool that may get that experience like Jorge has just had and what he talked about. But when you do come together, though, there is a force multiplier in some way. I think, and I think it's important to point out why that is. When you land in a program like Jorge is describing, and he has other people that are similar to him, similar ambitions, similar interests, maybe even some similar background or shared experience, but also similar challenges, right? Similar fears, similar barriers. Though all of that is what that's called is and what it creates is a sense of belonging. Like, oh, I'm in the right place. I'm in the right program, and because I belong here, and we're all together trying to achieve a similar goal. That is an antidote to, I would say, some of the to certain barriers, such as things like stereotype threat, imposter syndrome, right? These different sociological descriptions of behaviors that we know are real and very reproducible, and they have been proven out by multiple studies to exist. But so anyway, so I think Jorge is giving us a very good example of part of the antidote for that. And belonging and creating a sense of belonging in your population is a really important way to do that. I think that's also the reason why the mentoring programs and pipeline and enrichment programs work too, because people see you see mentors and individuals that have been able to make it through and provide you with a bit of a map, to where the landmines are, right, and what you should avoid, but also seeing that those people are approachable, and if they can do it, you can do it too. I actually got to co-author a chapter many years ago with one of my colleagues, Dr. Clarence Braddock, on underrepresented minority mentoring and development that was put out by the American College of Physicians. And I learned a ton in doing that. One of the things I learned within corporate America was mentorship programs actually work. And so the mentors don't always have to be culturally concordant. They don't have to be the same race or even the same gender or religion or anything like that. But again, acknowledging that that they're working together, that they may have implicit bias. They don't know everything about their mentee, maybe, especially if that's a person of color or someone with a disability or so on, right? They don't know all the background that and all of the social determinants that person might be bringing into the room, or their own in some cases. But I would just say those programs certainly work, and the networking programs that Elena talked about are actually. There's both, I think, anecdotal, but then I think there's starting to also be some evidence basis behind that's not anecdotal. It's actually proven to make a difference.
Yeah. I just add to the space. We have a program supported by the Office of Minority Health called the Nhma College Health Scholars Program, and we invite minority students. We started with the Southern California and San Antonio area to find more Hispanic students in those cities. And we had 5 conferences a year for a few years. And then last year, of course, we had to go virtual. But we had like 600 students for the virtual conference that signed up. Of course, they were on Saturdays, and students end up not realizing that they have other things to do like study or work. And so we don't get all the students, but I have to say we've had focus groups, and it was also a research study where half the students that would sign up for the conference, showing that they were interested, would be able to have the opportunity to get mentoring. Half the students got mentoring, half the students didn't. We have a site with all these different careers and opportunities for scholarships and study aids and that type of thing. But the mentored students, what we found, and there was significant difference, it's actually being written up, the paper is being written up, that there was a lot more self-confidence and a lot more, understanding that you could do it, and less anxiety, which is what a lot of what minority students especially have about test taking, studying. Most of these students were first generation without fathers or mothers that were doctors, who were not part of tutoring or, pre-med advising in colleges, and some in community colleges, some in, University of California, University, whatever. But the idea, I think, that students taken out of their routine and given an opportunity to actually learn from a mentor. And this was only once a month. But I think there was a lot more. And then we had webinars about social determinants of health and what is minority health, and what are the idea of becoming a minority doctor. What does that mean? It just all kinds of thought-provoking for health equity purposes, preparing young students to learn how to interview for medical school or dental school. But anyway, I just say that there's a lot of learning that takes place with mentoring about yourself and about how important it is to feel confident and to be able to have the more initiative to do even better as you're preparing each step of the way. So these were college students ready to apply or interested in applying to a health professional school, but you can see it at each level. And I'll just say, lastly, we're creating councils. Mm-hmm. I know the NMAs has had this for a long time. The idea of having specialty groups. So for internal medicine or for family practice or surgery, just general groups, but allowing residents to meet, have medical students meet residents and residents meet faculty in the same discipline, because it breaks down the barriers and you learn from each other right away how to ask questions and feel more comfortable about being around people in that discipline. And I think that that's going to grow the networks that we have even more to learn from each other. And that's how we can increase the diversity, by having more people encourage others to think about coming into this discipline or this profession.
That's great. Thank you for that. I want to keep building off of this concept of mentorship and what leaders on this call can do or take back to their organizations. And Jorge, I want to come back to you. If there's one thing that you think we should be, you're encouraged by and thinking about, you're starting to see your organization embrace, that's paying, helping us create the pipeline of diverse talent and putting forth more diverse perspectives to create the health equity that we're striving towards. What's something that you think you'd like others in this audience to take back to their own organization?
Yeah, that's a great question. There's one program that I'm not involved in, but it's so popular that I've been trying to get involved in. It's a wonderful program that the program has, where they actually connect with local, I think it's high school and undergrad students in the community. And basically, there's a bunch of different programs, but this was the one that jumps out to me. And they basically help them fund them to do research over the summer, essentially. And that program has been super popular. I tried to engage and serve as a mentor for a student last summer, and there was too many people. They were like, sorry, you're too late. So I think that those are opportunities where I think organizations can do things like that. Some of it is just like almost exposure to a lot of these career paths, because there's so I reflect on this all the time. Being an immigrant to the US, I feel like my parents were like, you're going to be a doctor and that's what you're going to do. And I was like, it happened that I also really like medicine, so it worked out well, but there's so many other career paths that you just don't know about. And I think as leaders in these organizations, reaching out to your local community groups, your schools, and being like, can we come speak to your students? Can we come have a few students over? Something to expose folks to different career paths that are just not the traditional, because there's so many things you can do in life. And so I think that's one thing I would take back as an organization, is reaching out to your local community and saying, can we show the students what we do and how this is a viable path for them, would be sort of a really powerful stance to take, and be like, we're trying to be more inclusive in the way we're developing kind of the talent pool going forward.
I love that. That's great. So impactful and purposeful. Ian, how about you?
I don't have a specific program in mind. I think maybe, but I agree with everything Jorge said. I mean, I think that is that is a great place to focus, and getting involved in local programs, or even now, you know, remote, you can do so many things remote. I mean, just being involved in a program where there's a national footprint, like national medical fellowships or something like that, may have some of those types of opportunities. It sounds like Elena has, you know, she's at the, you know, at the trunk of the tree there, you know, building and providing the roots for some of these programs to really flourish. So it's really an honor, honestly, to hear some of the work that she's been doing. So I'll take a different bent and just say, you know, I think in the, we talked a lot about the students and kind of how, like, having them like find mentorship, empower themselves, be focused on, you know, on themselves to make them be as strong as they can be. But I'm going to ask that those board members who are maybe part of the majority, right, are European American descendant males who have the board seat right now, or in the C-suite, and that might be thinking about appointing or reaching for a single person as, okay, and you will be my DE&I or my diversity officer. I think that's a great start. I think we need dedicated resources, but I want those CEOs to be the DE&I, like, I want them to own it. I want them to do their part, because we can work from one end with the students and mentoring and so on, but we don't want them hitting up against these glass ceilings, or for you to have unconscious bias and not give them the opportunities. And if you're in that seat, you're the only person, you know, you're at some point, you are the gating factor here. And so they need to own that. And I would say any company, so for instance, a lot of health plans right now are beginning to identify chief health equity officers. And I think that is incredible. And I have some friends that have stepped into those roles. And I would say, this is fantastic. And please, CEO, don't stop there. Grab other people to put around my friends, because they will do the work and they will work hard and they're committed, but please don't put it all on them to like be everything for the entire program. The chief diversity officer, equity officer needs to be the highest level person in the company, if you ask me. So the companies that are doing that, I would say, are the ones that I'm the biggest fans of. There's not a lot of them, and there's not a formal program for them. So I'm just applauding those who've done it, but also challenging those who have not done it to take their step.
I'll follow up with you, Ian. There's one that I was talking to yesterday, and I think what your point is actually really well taken, but it's got to be fully integrated into what the organization does, not just necessarily a silo or something that is, well, that's a branch. It's really kind of be fully part of the leadership team and the strategy. So that's great. How about you, Elena?
Well, I'm going to follow what Ian's talking about from the board level or from the CEO level. From the corporate companies, and I'm not any company interested in health equity, I would say, whether it's insurance, pharma, or hospitals, or those that are not in health that need to think about health. I think we need to go both ways. So for the, let's say, health professionals organizations, and we have a national Hispanic health professional leadership network made up of those national groups of health professionals that happen to be Hispanic. Nurses, there's dentists, the pharmacists, the physician assistants, there's dietitians, there's social workers. All these organizations, we're the medical association, we bring them all together at our conference and give them leadership awards. But all these organizations need the connections to the corporate sector. The corporate sector needs them for board members, maybe not a dietitian for, but a dietitian for a hospital system. Anyway, I think we need board members, all these different nonprofit professional associations need board members and corporate advisors, maybe not on their board, but corporate advisors, right? To be able to provide them open doors to finding more opportunities, those slots in the board vacancies for their members who are ready to go to that level. And we also, every Friday, we send out a nomination to our members about opportunities for leadership, because that's the whole point of having these organizations. So we're the alumni of the medical schools. We're the alumni of the public health schools in this country. And here we are, out on our own, trying to develop our own network. why aren't we working with those schools? You know, we all need to work with each other. Anyway, I'll just stop there, but there's a lot of opportunity in it. So I would say that those companies that Ian mentioned are interested in DEI, that are at the forefront of this wave that's not going to stop. And I think with everything that happened with COVID-19 and Black Lives Matter, there's a realization in the mainstream how important it is to connect to our communities through an office. But I think it's more important to actually connect to the human capital that we represent in the organizations of Hispanic and Black and Native American, Asian doctors and nurses and others.
Thank you. So many great ideas. And first of all, thank you all three for your leadership in this area and in your respective organizations on both coasts represented, which is great. As we close, is there anything we didn't get to that my panelists wanted to make sure we covered before we kind of bring it to a close?
I would just say I think Jorge started us off with a really great dilemma about technology and the adoption and what we need to do there. And so I would just put a plug in for, ideally there's more funding for better high-speed internet bandwidth to certain zip codes that really have been digitally redlined and don't have that. Yeah. There also could be programs that during a medical emergency or a public health emergency, not that those happen very often, but we've had one going on for the last year and a half to 2 years, where data plans and rates are reduced so that we can actually have because so many families that don't have broadband internet do have mobile devices and they have smartphones, and so therefore letting them be able to access care through virtual means, I think is a really, that's a, certainly I've drunk the Kool-Aid on that, but that is a very important tool in the tool belt that we have to improve access to care across zip codes, across the country. And actually, I think it really is an equity platform in my book. So I think more research in this area is needed, but I think we really should avoid the question, the challenge of and technology will automatically increase disparities in care and automatically make care more inequitable. That is not, I would argue that's the whole reason for telemedicine and virtual care was really to improve access. So, so I just don't want our politicians to get distracted. And I think they can, they can use the data that we learned during the public health emergency, not to tell the narrative of how people, all the misses, but I think there's other stories out there where seniors got better, we're getting better access to care. Within our own company, we saw over 50% of our patients coming from low-income zip codes early in the public health emergency. That was a change, and but the important thing is, even prior to the public health emergency, it was like 47% of our patient population comes from a low-income zip code where household income is less than $20,000 a year, and so so I think that I would say don't make up your decisions too early here about what technology can do. And we should certainly lean on our researchers like Jorge, who are doing the work to help us really find the truth.
That's a great point. I wholeheartedly agree. And I think also being helping build the awareness in our respective communities about the capabilities and the opportunities for that, and also just continue to relationship build. I think that was the main thing I took away today too, is we all are in a virtual world, but relationships still matter, whether you're mentoring or engaging somebody in the community on how to access some of these technologies. So I want to thank Jorge, Elena, and Ian. This has been fantastic. I learned a tremendous amount. I took 2 pages worth of notes, and I want to thank you for your leadership really on this topic and in your you're at the universities and the wonderful health systems you represent. So I know there were a lot of great questions in the chat. I don't believe there is a session to follow this. So Jen tells me we will adjourn, and I hope everybody goes away inspired and having learned some great things today. So thank you.
Thank you,
Thanks,
everyone.
everybody.
Thank you.
Thank you. And
Bye.
Well-
we'll see everybody tomorrow at 11 o'clock, bright and early when we get started again. So everybody have a wonderful evening.
Thank you.
Thanks very much. Bye.